Okay, folks, let's today talk about the meningitis. So, meningitis is basically the inflammation of the meninges. Now, the meninges are the envelopes that surround the brain as well as the spinal cord. So, meningitis is the inflammation of the meninges, and you can remember the meninges with the help of pad, the mnemonic pad, that is the pia mater, arachnoid mater, and the dura mater in the same sequence. So, now the causes of the meningitis. Now, the meningitis is mostly caused by the viruses. The viruses are the main cause of it, and once the virus causes it, so once you do the lumbar puncture in these patients, so there will be no bacterial cultures. So that's why this kind of meningitis is known as aseptic meningitis. So the aseptic meningitis caused by the viruses will have similar presentation as the bacterial meningitis, but if you do the lumbar puncture, then you will find the negative bacterial culture. Moreover, these patients will have lymphocyte leukocytosis, that is, they will have increased lymphocyte in the CSF as compared to the bacterial, where there will be increased polymorphonuclear cells in the lumbar puncture. So just remember these things. Now you can remember the viruses, the various viruses that causes the meningitis. So in that, first of all, you can remember it by the mnemonic HEAL. So there is HIV, herpes simplex virus, then there is enterovirus, arbovirus, in which you have the West Nile virus, and the St. Louis encephalitis virus. So those viruses come in this category, and then your L, that is the lymphocytic choriomeningitis virus. So these are the main viruses that cause the meningitis. Moreover, this meningitis can also be caused due to some bacteria, fungi, and parasites. Now remember, these bacteria, fungi, and parasites will also give the same findings on the CSF as the aseptic meningitis. So that's why they are placed in this category. So these fungi, so it is important to remember these things, because in these cases the lumbar puncture will not show you any bacterial culture, so you will have to do some specific diagnostic test based on their history. So if you say, for example, if you look at some specific organism here, so the Cryptococcus, which is your fungus, so the fungus will be present if the patient has history of HIV, and this HIV is so severe that they have the T cells of less than 100 per microliter. So if they have such a low count of the CD4 cells, so that means you have Cryptococcus infection. Now the second thing is the Rocky Mountain spotted fever, that will have a history of tick bite, and they will have rash. They will have rash that moves, that first of all erupts on the this rash will first of all erupt on their arm, and from there it will move to the trunk. In case of Lyme disease, there will be history of travel, and in this patient there will also be rash, but this rash will be targetoid in shape. So they will have targetoid shape rash. Moreover, they will have arthralgias as well as arrhythmias. So that's important things to remember in Lyme disease. In the case of TB, you will have night sweats, weight loss, hemoptysis, and meningitis. So these are the typical signs of the TB along with the meningitis. And TB will be present in homeless persons, in the people with prisons, with people with the poor socioeconomic status, and mainly the immigrants. So in these patients you can suspect TB. And the other thing is syphilis. Now in case of syphilis, you will have a history of the primary chancre, then there will be secondary erythema multiforme, and now the patient presents with the neurosyphilis. So just keep this history in mind. So now once the patient comes with the meningitis, you do the lumbar puncture. The lumbar puncture comes to be aseptic meningitis, that is, the typical finding of the bacterial meningitis are not seen. So now you look at these organism, any of these history, so you may go to the specific diagnostic test of that disease, because you cannot order the test for all of these diseases, of course. So you will have to look at the risk factors associated based on their history, and then you have to order that specific test. Okay, so this was all about the aseptic meningitis. Now the aseptic meningitis have relatively good prognosis as compared to the bacterial meningitis. Okay, so the thing to remember about the aseptic meningitis is that there will be lymphocyte leukocytosis in CSF, and there will be negative bacterial culture. Heel viruses cause it. Moreover, some bacteria and fungi and parasites can also cause it. So there is Cryptococcus, Rocky Mountain spotted fever, Lyme disease, TB, and syphilis. So these are the important things to remember. Now the next one, moving on to the next one, then there is first of all at the top, so there is non-infectious causes. So the non-infectious causes of the meningitis include, there are some meds, SLE, sarcoidosis, and carcinomatosis. So just remember these things as well. So these things can also cause your meningitis. Now coming on to the next we have the bacterial meningitis, which is the main meningitis that we remember. So the bacterial meningitis is of course caused by the bacteria, and in these cases this classification is basically on the lumbar puncture. So in the lumbar puncture you will find positive bacterial culture of these organisms, and moreover they will have, these patients will have increased number of polymorphonuclear cells. Now the bacteria that are causing these this meningitis are the group B strep, the strep pneumo, the Neisseria meningitis, Staph aureus, and Listeria monocytogene. Now you also have to remember the risk factor associated with each of these, that the group B strep mostly occurs in the neonates. The strep pneumo, once the patient is beyond the neonatal age, and it is most common cause of the bacterial meningitis. So the most common cause of bacterial meningitis is Streptococcus pneumoniae, but in neonates it's group B strep. Neisseria meningitis, they cause in adolescents, and moreover they will these patients will have petechial rash as well. Staph aureus, Staph aureus, since it is present on the skin, etc., so it will be mostly associated with patients who have undergone the neurosurgery. And then the Listeria monocytogenes, which mostly occur in the immunocompromised patient, and you have to remember the immunocompromised patient as an elderly neonate taking monoclonal chemotherapy for HIV/AIDS. So if it is elderly, that is greater than 50 years of age, neonates, then if there is chemotherapy, HIV, or AIDS. A neonate is basically someone with during their first month of life, so less than 28 days. So that is your neonate. So if less than 28 days, if greater than 50 years, if they are taking chemotherapy, or if they are having HIV or AIDS, so these are immunocompromised patients, and these patients are more prone to the Listeria monocytogenes meningitis. Okay, so these are all about the bacterial meningitis: group B strep, strep pneumo, Neisseria meningitis, Staph aureus, and Listeria monocytogene. Now one thing more here is Haemophilus influenzae. It used to be the most common cause in children, causing meningitis, but now since its vaccination is pretty obvious, so this now doesn't cause that much of harm. Now how the bacteria spread, this is another thing, that how the bacteria spread to the meninges. So the thing is that it may spread from the contiguous local spread, that is from the otitis media, sinusitis, mastocytitis, or some dental infection. They may go directly into the brain and cause your meningitis. The second thing is they may travel via blood. So in case of blood, in case of the endocarditis and pneumonia, so these infections, they can reaches to the brain and meninges via blood. Moreover, they can also move retrogradely via cranial nerves, but it is very less common. These are relatively more common sources. Now the next thing is their classification. Now coming to its classification, that how you will classify the bacterial versus aseptic. So how will you classify? So the first classification is that you can classify it via bacterial as well as aseptic meningitis. So it is usually means cause based, that whether it's caused by bacteria or non-bacterial, or mainly you can say that this is more of the lumbar puncture based. So if the lumbar puncture shows the positive bacterial culture, that's bacterial, and if not, that's aseptic. Second one is acute versus chronic. So there may be acute meningitis or the chronic meningitis. So the acute meningitis occurs when the onset occurs within the when the onset is within hours to days, and it's usually bacterial. Whereas in chronic cases, the onset usually is within weeks to months, and it usually occurs in TB, fungi, Lyme disease, or parasites. Moving further, now how will the patient present? Now this is an important thing to remember, that most of the patient that involves the brain and the spinal cord, or the brain and the meninges, so they present mainly the lesion, all of these lesions mainly present with the fever and headache. Now the fever and headache, these may be signs of some systemic disease. For example, it occurs in flu as well as in other tensions as etc. But how will you know that it's basically due to the CNS problem? So that is once there will be photophobia, phonophobia, or nausea or vomiting. So once these signs appear, so that means that you have got a CNS inflammation or some lesion in the brain. Now if you have all these and then you have positive neck stiffness, there is kerning and Brzezinski's signs are positive. We will discuss these signs a little bit later. For now, just remember that if these are positive, there is fever and malaise, as well as there is maybe altered mental status, but not necessary. So if these signs are positive, then it's meningitis. If there is focal neurological deficits, then it is due to either there is brain abscess or a tumor, and if there is altered mental status, it's due to the encephalitis. So that's the things to remember here. Fever and headache with phonophobia as well as nausea and vomiting, that's CNS. With all these signs positive, that's your meningitis. Now the various signs that we said that will be positive in the meningitis. So first of all is the kerning sign. So what is the kerning sign? Basically that you ask the patient to flex their hips at 90 degree, or you will flex their knees, their hips at 90 degree, and you ask them to extend the knees, and they will be unable to extend their knees, and it is due to the meningeal irritation. The second thing is Brzezinski's sign. So what's the Brzezinski's sign? That you flex the neck of the patient, and once you flex the neck of the patient, what will happen that there will be flexion of the legs and hips, and the patient will flex their hips as well as their legs in order to decrease the traction on the meninges. So if this occurs, then it is positive Brzezinski sign. So these two signs will be positive in meningitis. Now some special signs which occur some special cases. So first of all is the rashes. So if there is a targetoid rash, so it is due to the Lyme disease. If there is maculopapular rash with purpura, so it's the character of the Listeria Meningitis. Moreover, if the rash moved from the arms to the trunk, we have already talked about it, that it is due to the Rocky Mountain spotted fever. And if there are vesicular lesion, that is due to the varicella zoster virus or herpes simplex virus. So remember these special signs and the bacteria or the virus associated with it. Moreover, the facial nerve palsy is usually caused by the Lyme disease, and the pulmonary signs and symptoms are of course caused by the tuberculosis, and increased intracranial pressure signs in some cases will also occur in the meningitis. So these include the papilledema and seizure. So you have to remember all these signs. So these signs may be positive in the meningitis, and based on these signs you can assign the bacteria or the causative factor that is associated with this meningitis. Now just remember how we move from top to bottom. We said that this patient will have fever as well as headache, then there will be phonophobia as well as nausea and vomiting. So that we said that it will be diagnostic of the CNS inflammation. Then you want to find out these various signs. So if there is Brzezinski sign is positive, the neck stiffness is positive, the kerning sign is positive, so these signs will take your diagnosis toward the meningitis. Now in special type of meningitis, we said that there may be targetoid rash, maculopapular rash, or some the rash that moves from arm to the trunk, or the various different these signs. So these signs will take you to the specific diagnosis, that what was the specific causating factor causing the meningitis. Moving one step ahead, and now we will talk about the diagnosis, that how will you diagnose a patient of the meningitis. So first of all, in the meningitis we want to do the lumbar puncture to see what's in there. But before doing lumbar puncture, you will first have to find out that is it safe to do a lumbar puncture. Now how will you find it? If the patient has these 5 signs, then it means that it is unsafe to do the lumbar puncture and there is increased intracranial pressure, so you won't do lumbar puncture in these cases. You can remember it by the mnemonic fails, so that if there is focal neurologic deficit, altered mental status, immunosuppressed lesions, there is some lesions in the brain, or seizure, the patient is having seizure, so in these cases you won't do lumbar puncture. So if any one of these is positive, so it is unsafe to do lumbar puncture, and in these cases you will do head CT. In other cases, if all of these are negative, there is no such symptoms, then what will you do? You will do the lumbar puncture. Now, first of all, let's say if there were no such signs, there were no focal neurologic deficit or altered mental status or all these stuff, so there was no increased intracranial pressure. We did the lumbar puncture. Now, what you will send? You will send for the cell count, the culture, as well as the gram staining. Now, the gram staining is positive in 50 to 70% of the cases, but it has limited sensitivity. Similarly, the culture, it is most accurate test for the bacterial meningitis, but it takes time. So, the best initial test that you have got is cell count. So, once you count the cells inside the CSF on the lumbar puncture, so if there are thousands of the polymorphonuclear cells on the lumbar puncture, then it is typical bacterial meningitis. Otherwise, if the polymorphonuclear cells are not seen in 1000 and there may be lymphocytes, increased lymphocytes in the CSF, or there are no lymphocyte but there is no polymorphonuclear neutrophil as well, so in that case it is your non-bacterial meningitis, and it could be viral, fungal, Lyme disease, or Rocky Mountain spotted fever, or tuberculosis that we have talked about, the aseptic meningitis. So it is non-bacterial. Now the non-bacterial, you will look at the history of the patient, and then you will order the specific diagnostic test of these diseases. Say for example, if the patient has a history of the Lyme disease that we have talked about, the targetide rash, if it is having targetide rash, what you will do, that you will do specific immunological response and serology in case of the Lyme disease as well as Rocky Mountain spotted fever. If it is Cryptococcus neoformans, the fungus, then initially you can do it with the India ink, or you can also diagnose it with the help of the increased antigen in the CSF and serum. If it is syphilis, then you will do the VDRL, and if it is tuberculosis, then you will send for AFB smear, or you can also find out with PCR. So if it is negative in the non-bacterial meningitis, then you have to find a specific cause based on their history. But if it is bacterial meningitis, then it's okay, then you don't have to find the specific bacteria, because these bacteria that is causing the bacterial meningitis, they can be cured with same empiric therapy that we give to them. Now we did the lumbar puncture. Once we said that it was safe to do the lumbar puncture, what to do if it was unsafe to do the lumbar puncture? So in those cases you will do the head CT. But before doing the head CT, you have to give these patient empirical dose of the antibiotics, because it is better to have a live patient with bad diagnosis than a dead patient with a good diagnosis, because the antibiotics will alter our culture reports later on if we do the lumbar puncture. But you have to give these patients something in order to deal with the meningitis. So you have to give them empirical antibiotics. Forget about the diagnosis, let it be the bad diagnosis, but just first save the patient. Now it was unsafe to do the lumbar puncture, so you send this patient for CT. So now on the CT, if you see any mass lesion, or you may not see any mass lesion, so if there was no lesion on the CT, so you do the lumbar puncture again. However, if there was any lesion found on the CT, so what you will do in these cases, that if this patient has HIV and they have toxo antibodies, so you just consider that it is toxoplasmosis, because it is very common in the HIV patient. So you just consider it that it is toxoplasmosis, and you treat the toxo. Then you rescan after 2 weeks, then you rescan after 2 weeks, and then you recheck that whether the lesion that was present in there, whether it is improved or not. So if it is improved, then you continue the therapy, and if it is not improved, then you then do the biopsy and find out whether it is abscess or it is cancer. Okay, but if it is improved, then you continue the same therapy. If it is not improved, then you dig out further deeper. You look at whether it is fluid or it is solid, so whether it's an abscess or whether it is cancer, so you then treat accordingly. Now, on the other case, if the patient doesn't have HIV or toxo and there is some mass lesion on CT, so what you do, that if it is solid, then it is more probably a cancer, and if it is a liquid instead, that it is, if it is abscess, then what you do, that you drain, you aspirate that fluid, and then you look at it, that you culture it, you find out the bacteria causing it, and then you treat it. So in this case, so that was all about the diagnosis of the meningitis, the detailed diagnosis. Now, treatment. Now, in case once the patient come to you, if you suspect the bacterial meningitis, so start immediately start the empiric therapy immediately after lumbar puncture. So as soon as you do the lumbar puncture, you send the specimen CSF to the lab, so just start the empiric therapy. Now your empiric therapy should consist of the ceftriaxone, vancomycin, and or ampicillin. So the ampicillin is added only in the patient that are immunocompromised to cover the listeria. Otherwise, you just go with the ceftriaxone and vancomycin. So your ceftriaxone, it will cover your gram-positive and gram-negative cover, and vancomycin will cover your strep pneumo. Now the strep pneumo can be covered with the penicillins, but since there is large number of bacteria that has arose that are penicillin resistant, so you don't want to take any chances, and you just start with the vancomycin. Now if there is bacterial meningitis or there is cerebral edema, then you also give steroids to this patient. Why? Because if it is gram-positive bacteria that is causing this meningitis, what will happen, that once the antibiotics are started, they are gonna kill the bacteria, and the cell wall, the toxins will be released that will be causing inflammation. The further inflammation exacerbation, that will lead to increased mortality. So in order to prevent all those steps, you wanna give them steroid to decrease that inflammation. And once the culture reports come that if it is bacterial, then you continue the steroids for 4 days, and if it is not bacterial, then you stop the steroids. Now that was the empiric therapy that we have started, the ceftriaxone, vancomycin, and or ampicillin. That was empiric therapy that you just give them blindly to give them something. Now once the culture report, the lumbar puncture staining, the staining or the other diagnostic test, when their results come on and the specific bacteria is diagnosed, so then you treat them accordingly. Say for example, if it is bacterial meningitis, on the lumbar puncture, then just you continue the empirical therapy, and there is no need to further look at which of the bacteria is causing it. But if it is non-bacterial, then you have to find out the cause. Then if it is viral, if it come out to be viral meningitis, then you just give them supportive treatment such as analgesic and something for the fever, etc. In case of TB, you give them antituberculous therapy. Then in case of the Lyme disease, Listeria, or Rocky Mountain spotted fever, you give them ceftriaxone. In case of syphilis, you give them high dose IV penicillins. In case of Cryptococcus, you initially treat them with amphotericin, but that is for the amphotericin is followed by fluconazole for life. So fluconazole, they will take fluconazole for the whole life if they are HIV positive, and they will continue it until they are put on by the highly active antiretroviral therapy. So you will give them amphotericin, and then you will put them on fluconazole either for the whole life or in the immunocompromised patient, in the patient with HIV, or until they are on the highly active antiretroviral therapy, and they are asymptomatic with the CD cell count for greater than 100 for about 3 to 6 months. So just remember that you will treat them initially with the amphotericin and then on the fluconazole. So this is the whole detailed topic of the meningitis. Everything is explained. I hope you got my points, and do subscribe my channel. And if you have any question, then just put them in the comment section below. Thank you.